Welcome, everyone. We will wait a minute while everyone is entering the room, and I'll just wait to get the nod from our team that everyone is in, but we're very happy to welcome you to today's webinar on addressing financial exploitation in older adults through community partnerships. So we'll just give it another 30 seconds or so, and we'll get started. Okay, for additional people who have joined us, thank you again for joining us for our webinar today on addressing financial exploitation in older adults through community partnerships. And we will get started. We have a fantastic panel of guest speakers with lots of great information for all of you. And so want to make sure that we have time to get through their presentations, as well as giving you the opportunity to ask questions. My name is Kristin Reedy. I'm the director of the National Center for Equitable Care for Elders. We are a HRSA-funded training and technical assistance center that provides innovative and culturally competent models of care, interprofessional training, and educational resources to healthcare professionals providing care to older adults in the HRSA-funded health centers. And on this slide here, you can see that there's many ways to connect with us. We also wanted to share some COVID-19 resources as we are hopefully emerging out of the pandemic. Just want to make sure that you still have access to resources, and particularly to note that these are on the Health Center Resource Clearinghouse. This is a resource clearinghouse that not only gives you access to COVID-19 resources, but also resources for training and technical assistance that we provide, as well as many of our training and technical assistance partners. So today's webinar is in a Zoom webinar format. Please use the Q&A or chat box to ask a question during the session. And we do record our webinars, and you will receive the information after the webinar. And also, because we are a federally funded training and technical assistance center, we do appreciate your evaluation and feedback at the end of the session, and you will receive a brief survey. And so please fill it out. Also, please indicate if you have additional topics that you'd be interested in. And we can look at those and insert those into our future activities. So I'm going to turn it over to our moderator for this session, Dr. Peter Marimaldi, and he will take it away with our guest panelists.
Thank you, Dr. Reedy, and welcome everyone. I'm really glad to be here today because we've put together a really terrific panel of experts. Very quickly, I'm going to review the learning objectives and do a very brief level setting to put the context, give some context to what we're doing. If you're looking at the screen, you can see that we're going to start by identifying risk factors that would contribute to susceptibility, specifically to fraud and exploitation for older adults. It's a rampant problem, and it's a timely topic. We'd also like to try to explain some of the benefits and limitations to these social needs assessments and how we can identify elder abuse. It's very difficult because there's so much that we're asked to do in health centers. And then we're going to look at opportunities to share strategies and What kind of local organizations might you be able to identify to help support older adults who are at risk? Now, if I could please, to do some level setting, I'd like to just use a little bit of imagery for a moment. And if you've ever looked at constellations, if you look into the night sky, if you live somewhere where you can really see the stars, you get a sense of how there's just more stars than one can count. And if you've ever seen those charts where they outline the constellations in a star chart, that's kind of what it's like. Because if we think about, we used to use the term North Star a lot when I was in meetings. And what's the North Star for patients for health and well-being when they're coming to a health center? What guides them to the health center and when they get there? But in this context, if the patient is the North Star and we look at the patient, and can you imagine this? There's 88 constellations in the sky, and there's probably more issues that we're trying to identify in patients in health centers. But if you think about what we can identify as people working in health centers, what we're going to try to do today is in that array of stars, outline issues of elder abuse. And if you can get that image, it's so complicated, but hopefully the health centers are called upon to do just about everything these days. And if we can somehow get a way to see fraud or exploitation and abuse in elders, the health center might be a really great place to do that. But more importantly, how to connect people to their local resources, because we can't do everything from the health center, but maybe we'd be the place to start. Maybe we'll be that North Star that leads us to the constellation that we need to examine more closely. And with that, it's a real pleasure for me to introduce Elizabeth Petrie from the I'm sorry if I pronounced it wrong, Elizabeth, from the Administration on Community Living. Elizabeth's going to talk about her area of expertise. We're also very fortunate to have Julie Schoen here from the National Center on Elder Abuse, and Kristin Lees-Haggerty, who's a project director and from the National Collaboration to Address Elder Mistreatment. This is a very distinguished panel. So Elizabeth, please, and correct me on the mispronunciation of your name, please.
Thank you, Peter. Thank you for that kind introduction. And it's my fault because I confused you with all of the various mispronunciations of my last name. So my name is Elizabeth Petrie. I am an aging service program specialist with the Administration for Community Living, which is a division of the Federal Department of Health and Human Services. It's a pleasure to be with you today. Just to kind of give a brief overview of what is ACL and how are we connected to elder abuse. So the Administration for Community Living, or ACL, was established in 2012. It brought together existing offices within HHS, including the Administration on Aging, the Office on Disabilities, and the Administration on Developmental Disabilities. More offices and divisions have since become a part of it, but the vision for ACL was to bring together sort of the constituencies of serving older adults and people with disabilities to ensure the vision of community living could be made real, that people have the right to live where and with whom they choose and to fully participate in their communities. Next slide, thank you. So our vision for elder justice, and I am in ACL's Office of Elder Justice and Adult Protective Services, is a comprehensive multidisciplinary approach that effectively supports older adults and adults with disabilities so they can exercise their right to live where they choose with the people they choose and to fully participate in their communities without threat of abuse, neglect, or financial exploitation. So very timely for what we're talking about today. And you can see from these sort of various trapezoids that our work is sort of diverse. We have many different areas that tie into elder abuse. We have legal services, programming, including grants to Title III-B of the Older Americans Act, providers for legal services to older adults, the National Center for Law and Elder Rights, and the Legal Assistance Enhancement Program grant portfolio. We have projects that are related to elder financial security, income security, including pension counseling projects, the National Pension Assistance Resource Center. We work hand in glove with the Office of the National Long-Term Care Ombudsman Program, which supports state ombudsmen across the country through a resource center. They also have a data system on ombudsman visits and how they support residents of long-term care facilities. We have a variety of elder abuse prevention projects, including some of what you'll hear Julie talk about in a moment, including the National Center on Elder Abuse, World Elder Abuse Awareness Day, grants to encourage innovations in the field of elder justice, to reduce late life domestic violence. And then the programs that I'm most familiar with in my day-to-day work are those targeting state adult protective services agencies. So grants to those local agencies, facilitating the development and regular updating of voluntary consensus guidelines for adult protective services. And you'll notice the title, Voluntary Consensus Guidelines, is very critical because there are no federal regulations that govern adult protective services across the country. It is very unique from state to state. We also created and manage the National Adult Maltreatment Reporting System, which, if you can imagine that there are no federal regulations, collecting standardized data across the country is its own challenge. But through NAMERS, we have states map to a set of shared data values, and we're able to do some analysis. That data system is entirely voluntary, but we have 100% participation from all 56 state territories and the District of Columbia. We support the National APS Technical Assistance Resource Center, and just in the last 18 months, we had the first ever targeted mandatory formula grants to state APS programs. Those were funded through the Coronavirus Relief and Response Supplemental Appropriations Act and the American Rescue Plan Act. And I am just going to pop in the chat a link to our website, elderjustice.acl.gov. So if you're curious about more of our work, you can check that out there. Next slide. So what is elder abuse? It is the mistreatment or harming of an older person, including physical, emotional, or sexual abuse. It also includes neglect and financial exploitation. It's an injustice that we all should seek to prevent and address. So we heard Dr. Marmaldi talk about how health centers can't do everything, but you're one part of the ecosystem of building strong support for older adults so that when they encounter abuse, they are quickly connected with resources to prevent future maltreatment and to encourage them in their healing. It is underdetected and underreported. It is multifaceted, and different forms can occur at the same time. So we're talking primarily about financial exploitation today, but it's key to note that where there's financial exploitation, there may be other forms of abuse occurring simultaneously. And it occurs in the community and in institutional settings. Next slide. So we've all heard a lot about our demographic shifts. 80 million Americans will be aged 65 or older in the next 15 years by 2040. So nearly 21% of the population. And the most recent prevalence studies, and this has been duplicated a couple of times, state that about 10% of Americans 60 plus experience at least one form of elder abuse every year. 67% of those abused that we know of are women. Only 1 in 24 cases are reported. So let those numbers kind of marinate. This is a problem that is increasing importance. And so, as I mentioned, we have the multiple kinds of elder abuse. You can look at these definitions. These do vary in statutory language from state to state, but these are pretty generic definitions that should fit wherever you are within the country. One to note, self-neglect, characterized as the failure of a person to perform essential self-care tasks, and that such failure threatens his or her own health or safety, does not involve a perpetrator. That would be when you're concerned about an older adult, not because there is another person causing the harm, but because there is something else going on with that person that is causing this threat to their health and safety. That often involves behavioral health issues, could involve cognitive impairment. So just to note, not all states investigate these exact definitions. They may be called something slightly else, slightly different, but these are kind of the key groups. Next slide. And to zero in on financial exploitation, I think something that is important to keep in mind is that it could be perpetrated by a known or trusted individual, such as a family member or a stranger. So as you listen to the following speakers, note that there are a variety of ways that not just older adults, but all of us fall prey to scams and frauds, but that the financial exploitation by known and trusted individuals and by family members is really insidious and can cause a variety of other problems down the road. So it is my pleasure to be with you here today, and I'm happy to turn it over to our next speaker and to talk to you a little bit later on about potential resources and to answer your questions. And thank you for having me.
Thanks, Elizabeth, so much. It's just such a pleasure to be here. It's been so fun working with this team. We've had a great time sharing information and getting to know each other more, and that's the root of all of us working together to prevent elder abuse. It's this collaboration and teamwork that I've experienced with this group. And so I'm Julie Shane. I'm the Deputy Director of the National Center on Elder Abuse. And I'm going to tell you a little bit more about that in just a moment. But we receive a grant from the Administration on Community Living to fund us here at the Keck School of Medicine of USC. So it is, I think we can go to the next slide, Juliet. There we go. And this is what you would find when you would go to our website. This would be the opening page. And it would tell you that we are working to strive to improve the national response to elder abuse, neglect, and exploitation. And with all of your help, I think we can get there. If you look at the bar below, you'll see a number of names listed there on Elder Justice, APS TARC, NAMERS, there's ours, NCEA, NICLR, NORC. These are all our sister agencies, our partners. We collaborate, we talk, ACL facilitates regular meetings where all of us share information so that we don't stay isolated, so we know what each other's doing and that we support each other in our endeavors. And when you come into the website, I want you to, again, as Elizabeth was pointing out, we are focusing a little more toward financial today, but we also want you to know we're here for you in so many other ways because we deal with all the types of elder abuse. And with some of you as healthcare professionals, those physical aspects of abuse, the emotional aspects of abuse, so important to you too. So we want you to know that when you come to us, there's all types of resources, and we don't want you to have to reinvent the wheel on anything because we can support you in that. You can phone us with questions, you can email us, you can follow us on social media, and we hopefully can problem solve together and get to the root of what is happening. So that leads into presentation today. So we'll go to the next slide. Elizabeth did a great job of laying out for you the different types of elder abuse and the definitions that involved. But what we really need to understand is what causes elder abuse. And no more time has this been exemplified as during COVID. We have seen the increase of elder abuse in so many ways, particularly financial scams, due to the highest risk factor of all, and that is social isolation. And I'm going to kind of walk you through a little scenario in a moment, but some good studies are coming out, some good research is coming out on what has happened during this time. At the National Center on Elder Abuse, we do what we call technical assistance. We have people phone us or email us with problems. Now we're a resource center and not a hotline. So what we're doing is connecting people with the right resources in their area. But we are also tracking where that person's calling from, who it is that's calling, a family member, the person who's experienced abuse themselves. And we're putting that all into statistics. So a study is being done by the Han Research Lab on exactly what we've experienced the year prior to COVID and year during COVID. So we should have some interesting statistics coming out for you quite soon. The paper is being kind of finalized now. We're already seeing some very interesting aspects of what's happened during COVID. And then, of course, people's lack of access to support services and community resources feeds into that problem. And then just all the physical, mental, or emotional needs that people have in carrying out daily activities. And that leads to the next slide. I always like to take people on a little journey here because we work a lot with law enforcement. I'm going to mention a project we work on in just a moment. But they always say to us, well, Julie, they gave the money to the person, or, what do you want us to do here? This is, they're just a little exasperated because the understanding is, they made a choice and they did this, and is it really a crime if they have capacity and they know what they're doing during this, which is always the key element here. But I want you to think of someone who's older, your family member, yourself, a neighbor, and think about what they might be going through. And as you get older, sometimes your visual acuity lessens. I'm a newspaper reader still. I love it. I just love the physical, aspects of it all. And if my eyesight were failing beyond the reading glasses I have now and going to macular degeneration, this is what a newspaper would look like to me. And what a frustrating experience that would be reading. It would take that pleasure of reading and really diminish it. And now my world becomes a little smaller because my trusted resource for getting information about scams and programs and things is just becoming smaller. My world's becoming smaller. And the same can happen with television. If you get your news through television, your input that way, now it's not such a pleasurable experience. It doesn't have the intensity that it had for you. Or if you add auditory loss here, and now you can't hear the news, and it's, not as pleasurable, your world becomes smaller and you're missing somebody telling you about the most recent scam is, be on the lookout for. So all these things begin to isolate a person even more. You can be isolated in a crowd. How many of us have been at a party and it's just really noisy and we get tired of saying, excuse me, can you repeat that again? At a certain point, you just kind of sit back and smile and nod, and you may have missed some vital information about something that's happening, or in some church group or membership that you're in, and somebody saying, hey, did you hear about this? And you miss that. You miss these shared information that can help protect people. And now if you have limited mobility, you're unable to get out of the house by yourself, you have to rely on someone else because you've lost your driver's license, or it's just a pain to get in that wheelchair into the car or the walker, and you have to be dependent on somebody else to make those arrangements to get you out. Again, you stop asking and you get isolated. So when that phone rings and it's somebody on the phone who wants to listen to you and is saying, gee, during COVID, we can get you on this clinical trial. All you have to do is give us all your information and your bank routing number for some strange reason. You want to listen, you want to hear about it. This person's paying attention to you. If you won the lottery, even better. So I know when we read about these things, we wonder how people could do it. It's easy. And as Elizabeth pointed out, it happens to people of all ages, not just older people, but when you're this isolated or cut off, you might have more of a susceptibility to lean into some of these scams. So I hope that helps to build a platform for some of the next parts of the presentation. Okay, so in the next slide, we want you to be looking for these emotional signs, behavioral signs of elder abuse. And it might be subtle things like, just an increased anxiety, which I think everybody's been feeling lately. I don't think that's exclusive. I think we've all had that happening. But that isolation, somebody who was more involved, who was checking in, was finding out, what was happening, starts to withdraw. Not sleeping well definitely can be a sign of anxiety, and just withdrawing from those normal activities, which, let's face it, we all were kind of forced to do some of that just recently. And then the next slide, in talking about some of the financial signs of elder abuse, what is often found are the fraudulent signatures on financial documents, someone who's never used an ATM card ever, and now suddenly there are withdrawals every day for the maximum amounts. Banks are getting very good about reading these things and pointing out these warning signs. There's been some really great programs to help alert bank staff to things that are happening financially to some of their older adult members. And then also just something that would happen with piles of unpaid bills. And, you know, postal service workers are encouraged to report when they see stacks of mail out front of an older adult's home. There's some really good safeguard programs that are out there, but we want people to be aware of those signs and call and report. And they often call to us, but there's many other resources too that I think we have a list for you at the end of the presentation. And so we want to be looking for all these different signs of elder abuse moving forward. Okay, because elder abuse is preventable. That is the good news. You know, we're all aging. We all want to live in a world that is free from abuse. And so that's our mission, to create that for us all and to move forward. And so let's talk about some of the tools we have for you moving forward. So if you liked some of the graphics you saw, some of the icons and the things that I was utilizing, this is part of our support and tools for elder abuse prevention STEEP project. You can download these brochures and customize them with your logos and your phone numbers, whatever you'd like. You don't have time to put together all these things. You have a lot of things on your plate, but we have them for you, and we would welcome you to take them, to utilize them, brochures and fact sheets and a calendar of events and things like that for newsletter templates. So just want you to be aware of these things happening. And we did this in context with, I'm sorry, I need to update this on my slide. It says N4A, which was the National Association of Area Agencies on Aging. It's now called US Aging. So I'll have to update that logo on there for you, but they've been an amazing partner, and working with them throughout the country has really helped us to give people these materials and to make them accessible. So I want to make them accessible to you also, and we would welcome you downloading them, using them, no permission necessary, definitely. Okay. And then a project that we've been working on for several years now is the Reframing Elder Abuse Project with the Frameworks Institute. And we used to literally not be able to get people to come to the table and talk to us. It was like, oh, elder abuse, that's very messy. I don't think there's too much we can do about that. You know, it was something where we couldn't engage people. And with the help of the Frameworks Institute, they have said, you know, you need to approach this differently. And this is a way of approaching. You can use the QR code to access the online educational program that we have, that Frameworks hosts on their site. And you can learn more about reframing, because it really does bring people together, talking about elder abuse as a social justice program. And that makes all the difference, plus the support that brings in all of our agencies working together. As it says, it elevates public exchange on the topic, and it really is moving the needle forward. I have seen so much in the past 5 years I've been with this project of growth and potential. So I encourage you to look into this at your leisure, which you have so much of, right? So on to the next. Here's a listing for you. So when you have the slides, you can just go through and look at these. I'm going to show you a slide on the training resources on elder abuse, because if you want to learn more about financial elder abuse, there are many things already created. And again, you don't need to reinvent the wheel. I just mentioned Reframing and the STEEP project. And so let's go into World Elder Abuse Awareness Day, which is the next slide. Yay, June 15th, everybody, get ready. This is a day that globally we work with people on elder abuse. This is a global issue as our globe ages. And what we find is that, we've been working with Australia. Canada has a lot of amazing resources. India has a whole different concept on elder abuse. It's just that issue of disrespecting your elders is something that we could mirror a little bit more of. And it is just been fascinating to work across the globe with things that are happening with elder abuse. If you're doing anything, we'd love to hear about it and post it on our website. And there are many tools and brochures and activities. You know, it's just fun. If you're on your campus, you want to get people involved with a virtual walk or whatever, it's there for you. And it's a nice team building exercise too for you. So that's one of the resources many of the resources we have. So I encourage you to look at that. And then next, this is a very exciting program. And since many of you are practitioners, I would really encourage you to participate with the ECHO project, where we have primary care providers doing a 5-part series. And maybe you know Dr. Laura Mosqueda and Dr. Bonnie Olson. They are doing this series on identification and clinical management in primary care dealing with elder abuse. And it's been very well received. So this is another resource where you will learn more and learn a little bit more on the capacity issues behind financial abuse, which is becoming a big area of study. Okay, on to the next. And then this is a project I want you to be aware of. This is our EAGLE project. This is funded by Department of Justice. Law enforcement, we're really trying to get them to the table on elder abuse cases and awareness. And this is our project to do this, but also it has great resources for you. If you've ever been curious about what prosecution codes are available in your state, there's an easy zip code finder for those types of things, and the resources in your area. I won't belabor it too much, but it's just been, I've learned so much on both sides of the story of what law enforcement encounters with these cases and the hurdles that they face, and then hopefully providing them some tools in which they can be more effective in helping people as they navigate some of the scammers and the different, so many layers and complexity of elder abuse. And the next slide is where you can go to Treya and find everything you could possibly want about elder abuse in different, it's all there for you, all the different types. A lot of people need help with sexual elder abuse areas that people like to discuss as much. There's some really good information for you here. So I think I'm kind of going over my time. Apologies, Kristin. This is my thank you and contact information. And it's my pleasure now to turn everything over to Kristin Lees-Haggerty, who has a phenomenal project that she wants to introduce you to on the Collaboratory. So Kristin, thank you.
Thank you so much, Julie. So yes, I am Kristin Lees-Haggerty. I am a project director at Education Development Center, and most relevant for today's presentation, I'm project director for the National Collaboratory to Address Elder Mistreatment. I think we can go to the next slide, please. So there's 3 kind of broad categories I want to share with you all today. One is what the National Collaboratory to Address Elder Mistreatment is. The second is to tell you a little bit about the Elder Mistreatment Emergency Department Toolkit. And then the third is to zero in on one aspect of the toolkit, which specifically focuses on how do we build connections between hospitals and community-based partners so that we can help keep older adults safe once they leave the hospital setting. So next slide, please. So the National Collaboratory to Address Elder Mistreatment, we are a group of elder mistreatment researchers, clinicians, federal and community stakeholders who came together with funding from the John A. Hartford Foundation, the Gordon and Betty Moore Foundation, and the Health Foundation for Western and Central New York, with the goal of designing and testing a care model for addressing elder mistreatment in healthcare systems. And specifically, we focused on the emergency department. That's because we know that emergency departments disproportionately care for older people with known risk factors for elder mistreatment, and that they are well positioned to identify and address elder mistreatment, in that for the most vulnerable older adults, the emergency department may be actually the only time that they interact with healthcare providers. The emergency department is open 24 hours a day, 7 days a week, and there are typically a variety of different providers that will care for a single patient. So there are many different opportunities to observe signs of elder mistreatment in the emergency department. I should say we're starting with the emergency department because we are seeing ways that our model, our toolkit, is relevant for other settings and is starting to be used in other settings. But we also know that there are barriers to screening and responding to elder mistreatment in the emergency department, things like staff overload, lack of adequate training, and lack of adequate tools for helping to screen for elder mistreatment. as well as competing initiatives. So we had our work cut out for us. We partnered with some leading experts in the field. Our founding partners are listed here. Among them is the Keck School of Medicine, and Julie's team at the National Center helped us a lot on this project. And then next slide. Over the years on this work, we've also partnered with a variety of different clinical sites and federal partners, including ACL. So thank you to Elizabeth and the team there. And so that's just to show you that we've got a wide variety of partners here. I'm not going to spend any more time on that slide so I can get into the good stuff. So the goals of the National Collaboratory really at the outset were, let's reduce the number of missed opportunities for identifying elder mistreatment in the emergency department. Let's increase referrals to appropriate authorities and community-based services. And hopefully let's reduce repeat victimization and return to the emergency department. And so next slide. Here I wanted to share the perspective of one older adult who participated in interviews where we were asking older adults, what do you think about screening for elder mistreatment in the emergency department setting? And this person said, well, getting trapped in this environment that you can't get out of, in a position of going to the emergency room for that kind of abuse, I can guarantee you the reason that they're there, it's not the first time they've been abused, it's the worst time that they've been abused. And I think this points to one of the things that we really try to get at with our toolkit and our screening protocol is if an older adult is going to the emergency department specifically because of an injury that was elder abuse related, there were probably many, many missed opportunities for identifying that abuse before it became so severe. So I just share that to kind of frame the work a little bit. And what we try to do is take a person-centered, person-directed approach to the work and remember throughout all of this that we're doing that older adults are really centered to what we're trying to accomplish here. Next slide, please. So what is it that we're inviting emergency departments to do to address elder mistreatment? We're inviting them to implement a toolkit, which is called the Elder Mistreatment Emergency Department Toolkit. And this is a streamlined set of tools that's aimed at helping emergency departments better identify and respond to all types of elder mistreatment, including financial exploitation. The toolkit includes 4 core elements, and these are designed to fit into the existing staffing and workflows of diverse emergency departments. So we were really careful in designing this to not just design something that could be implemented in a large academic health center. We wanted to design something that could be implemented in large urban hospitals, small community hospitals. And we've done now a feasibility study, I'll say a little bit more about, that helped us determine that it is possible to implement this model. And the model is flexible enough to be picked up and used by various emergency departments. Let me tell you about the core elements. The first is a very brief online survey that assesses staff perception. So this is a survey that emergency department staff and other staff in related departments, so maybe there's a social work department and it would be relevant for them to also take this survey. And what this does is help assess what's currently happening around elder mistreatment practice, how aware of or how available are resources for addressing elder mistreatment, and what changes are needed. By participating in this survey and seeing the results of the survey, that helps to drive some of the practice change that we're asking emergency departments to do by implementing the following models. So the second are online training modules, and these are online interactive e-learning courses that train on what elder mistreatment is, how to report, and specifically how to use the elder mistreatment screening and response tools, which is the third element. The screening and response tool is an algorithmic screening and response tool that begins with a very brief 3-question pre-screen. It includes 3 questions. One of those questions is specifically about financial abuse. And one of the reasons we included that is actually, to my surprise, at the beginning of this project, the emergency department care providers said, we want a question on financial exploitation. We see it and we don't know what to do next. And we need help identifying and responding to that specifically. And honestly, I was surprised because I thought it would be easy for healthcare providers to say that's outside of the scope of our work. And they really didn't. They wanted to catch it and they wanted to address it. So 3 very quick questions along with observational red flags. And so it guides clinicians in how to observe signs in an older adult themselves, in the way that their caregiver presents, and importantly, the interaction between the older adult and the caregiver. And these are things that they're trained on. And then it's a very quick checklist in the screening tool. And then there's a longer, if there's concern based on that very brief screening tool, there's a more in-depth screening and response tool that helps determine whether there's a concern for elder mistreatment, whether they should report to Adult Protective Services or other authorities, how to work with the patient to come up with a safety plan, make referrals to community-based resources, and discharge the patient to a safe location. And then the fourth core element, which is really, really critical, is the Community Connections Roadmap. And this is a roadmap for leveraging community resources to help support patient-directed discharge planning and follow-up for older adults who may be experiencing elder mistreatment. What we learned when we were doing the formative research for this work is that providers in the emergency department said, sure, we can screen, we can ask those questions, but I'm not going to screen if I don't think that there's something I can do next to help the older adult. And so it was really important for us to build a piece of this toolkit that would help set the hospital up for so what next? And I'm going to say a little bit more about the Community Connections Roadmap in a couple of slides. So let's go to the next slide. This just shows a kind of clinical workflow map of how the toolkit might be implemented, specifically the screening protocol. And sites do it differently, but at some sites it will be one staff member that uses the brief screen either at triage or at patient bedside, does the brief screen, and then if there's no concern, after that very brief screen, it's just ED care as usual. If there is any concern, they would hand off to another provider, or they can move into it themselves if they're trained to do the full screen, the more in-depth screening protocol. If no concern based off of the more in-depth screening, ED care as usual, or if there is concern, they move into that response protocol, which as I mentioned, walks through reporting, safety planning, and referral and discharge. So that's just kind of a graphic example of how that might work. As I also mentioned, we did conduct a feasibility study. We wanted to know, can the toolkit be implemented in emergency departments? Does it help them better identify and manage elder mistreatment when they do use it? And how does implementation of the toolkit affect ED functioning? In other words, does implementing this toolkit kind of blow things up at the ED and make it unmanageable for them to do their other priorities? And what we learned, I'm not going to get too much into the data for the purpose of this presentation, but I'm happy to follow up with anybody that's interested. But we learned largely that it was successful, that we worked with 5 diverse hospital emergency departments who were able to implement the tool. In my opinion, the most compelling finding was that despite the challenges, we started the feasibility study right as COVID-19 hit. And so despite the challenges of the COVID-19 pandemic, all sites continued to use the model, and screening rates at every one of the sites increased over time, over the 9-month study period. And we screened over 15,000 older adults for elder mistreatment. We're currently taking the results of the feasibility study and revising the core elements slightly, but the toolkit in its current form is actually available on the Geriatric Emergency Department website, and I'll say more about that and share the link very soon. So next slide, just to give you an idea of the sites, the 5 sites in the darker purple are the sites that were officially participating in the feasibility study. And then the VA Emergency Department in Cleveland, Ohio is implementing the model now, but started later, so they weren't part of the feasibility study. But we're actually seeing that it's been successful at the VA in Cleveland, Ohio, and we're seeing spread in the VA. So we're really pleased with the initial results of the feasibility study and what we're seeing as it kind of organically spreads from these sites. The next slide shows kind of some overarching lessons learned. The first is that it's possible to do this. It's possible to do it in those large, high-resourced and in the smaller, lower-resourced emergency departments, but that they're going to do it in different ways, and they're going to need to vary the workflow in ways that work for them. For example, at one of the smaller community-based hospitals, it was important to them that they had a single staff, that they had all staff people trained on how to use the full screen, so that a single staff person could go from brief screen right into full screen and right into response protocols. At some of the bigger, more high resource, they could say, okay, the nurses will just do the brief screen, and then if there's concern, we have specialized staff they can hand the rest of the process off to, and that worked better for them. We learned that having a clinical champion is really essential to being able to do this work, clinical champion to both champion the model itself and oversee implementation, and to be a sort of on-site expert in elder mistreatment. So the clinical champion receives additional training in elder mistreatment and is an on-site resource. Many of the sites were using paper screening tools for the purpose of the feasibility study. We learned they really need to be working in the electronic health records. So we're working on getting the screening tool into Epic and Cerner right now. As I think we know, strengthening connections with the community is absolutely critical. And I'll say a bit more about that with the next piece. And that there are opportunities to provide services to other vulnerable adults identified through the screening process. And so without getting into too much detail, there is the option after having implemented the full screen that you could say, you know, I'm not concerned that this person is being abused and that maybe it doesn't rise to the level of the APS reporting, Adult Protective Service reporting requirements in my state. But this is a person that has some risk factors and could use some similar services, and you can still use the response protocol with that type of patient. So it doesn't have to be a grave concern that there's an immediate danger for this patient and abuse happening right now, but trying to also connect patients earlier in the process before it gets worse. And then next slide, please. So I wanted to talk, I wanted to kind of focus in on that fourth core element, which is the community connections roadmap. And as I mentioned, we learned early on in the process that we need to support hospitals in having something they can do next. And it's not going to be feasible for every emergency department to follow up over time with every patient that comes in the emergency department and is identified. So what kind of handoff can we do from the hospital to the community? We also learned there is this great model in elder mistreatment called multidisciplinary teams, but not all emergency departments have the resources to stand up a full multidisciplinary team or to even join one that's existing in their area. So what we did is we developed a roadmap that walks through 3 steps in terms of connecting with community resources. And in this model, you see the first kind of point on this continuum is report. The most important first connection that we recommend hospitals make is engage with your local adult protective services. This will help you to understand what the criteria are for reporting and make sure that you and your staff are able to fulfill your legal and ethical obligations as mandated reporters. Also, adult protective services often can help you connect with other community resources in the area. The second step is once you've created that single, so all we're asking you at first is make one single connection, make APS a connection, have a name there that you can talk to. Then when you're ready, you can add additional connections that are really focused on the priorities of your hospital patient population. So what are the most important needs of the patients that you're seeing at risk for elder mistreatment, and focus on those individual connections. And then third, if and when a site is ready, we do recommend that if at all possible, you formalize some sort of elder mistreatment team. This may mean joining an existing multidisciplinary team. It may mean reworking or adding to an agenda for a different team. Many hospitals have some sort of aging related multidisciplinary team. So add elder abuse to the agenda for those meetings and have a place where you can discuss and share resources. The graphic here shows too that there might be movement back and forth within this continuum, that sometimes we have knowledge that leaves with a certain staff member. And so you may need to back up and say, oh, we need to reconnect with APS and start the process over again, or move within these different bubbles. And I think the point of this roadmap is at some hospitals, there are existing resources. There's a great social work program, but even if there isn't a social work department, even if there is a social work department, they aren't always aware of the resources that are specific to the aging population. And so walking through this toolkit, whether or not you already have case management and social work thinking about similar issues, it's important to do so with an eye towards elder mistreatment specifically. And so we have created this toolkit to hopefully make that a pretty light lift for hospitals. And then the last thing I'll say about this is we have seen a lot of excitement around the Community Connections Roadmap since we did the feasibility study, and we've seen some sites that have actually made a lot of progress. And so, for example, in Niagara County, New York, we had the hospital working with the Community Connections Roadmap, and we're now doing sort of a place-based model where we're also working with specifically the community organizations outside, and they have done a lot of work to come together. And we'll be using what we learned from some of the qualitative work that we're doing there to build out additional tools and resources for the Community Connections Roadmap to be used nationally. So that was a lot of information. I think that's my last slide. I'm happy to take any questions, or is there more presentations next? Yes.
We're gonna do a quick, I think, resource wrap up, and then we'll go into questions, Kristin.
Okay. And I'm going to just share a couple of links in the chat because you can access all of these tools for free if you are interested.
Awesome. So I just wanted to once again thank Julie and Kristin for everything, and also to just highlight a couple of resources that you may have heard us mention and how you can learn more about them. So Kristin and Julie and I all talked about APS. APS, as I said, looks different from state to state, but there is an adult protective services program in every state. And you can find your local APS by going to the elder care locator. You can also find many other services that are available by zip code on the elder care locator. That link is in the chat. Long-term care ombudsmen are a resource available in nursing homes, long-term care facilities. They are extremely patient-directed, but they can be an advocate for patients in that kind of a facility. If you are concerned about fraud with an older adult, I also wanted to let you know that the Department of Justice has stood up a national elder fraud hotline. You can call. That is a live, it's manned by live kind of navigators who will work with a person to help them understand, you know, depending on how they've been scammed, how to report it. Oftentimes with like government impersonation scams, it can be tricky to understand, you know, which office of the Inspector General am I supposed to contact? They walk you through that, let you know exactly what should be reported to whom. And that is also available in the chat. They have, and the phone number is on the slide. And then something we did not have time to talk a lot about, but that can be helpful for clients who are trying to recover financially from financial exploitation, is the model of medical legal partnerships. So we have a current grantee, one of our legal assistance enhancement program grantees is a federally qualified health center in Michigan, Cherry Health. They have a partnership with their local legal aid where there's an attorney embedded on site and meets with clients. And even if you don't have a formalized medical legal partnership, knowing who, as Kristin said, your local partners are in the community and who you can refer people to want to understand their options when they're trying to recover, having legal aid in your back pocket is hugely helpful. So, and then Dr. Reedy also put a link to the National Center for Medical Legal Partnerships. So if you're interested in maybe, starting a medical legal partnership in your clinic, that would be an excellent resource for you. And I think we're ready for questions.
Thank you very much. Thank you very much, Elizabeth, Kristin, and Julie. This is about as state of the art, I think, as one can get. As someone who made their first report of elder abuse in 1986, this gives me hope to see how much we've gained in terms of protecting elders in the United States. It's absolutely wonderful. If there are questions from the participants, you can put them in the chat, and we'd love to take advantage of this assembly of experts here. Does anybody want to add anything, or I have some follow-up questions as well? Any of the presenters want to add anything? So very quickly, Kristin, this community roadmap, could that be adopted now in community health centers, or is it still being tested?
Absolutely. It is what I call a living document because we are constantly improving it, but its current form is available at the Geriatric Emergency Department Collaborative website. And I think it's one of the elements that can apply to many different settings, not just the emergency department. So I would encourage people that are interested to visit, download it, take a look, and we would love any feedback on it. So if it looks useful, but it could use some improvements for your setting, we'd love to learn that, and we will be updating it.
That's terrific. I would encourage anyone who has the wherewithal or the interest to please get in touch with Kristin about this. Very quickly, if I may, Julie, you know, the infographics I find very helpful for training staff or just heightening awareness. This customized, this tailored tool for infographics, what a great resource. But I wonder, you mentioned the ECHO project. How aware are police chiefs or police departments? Are they aware of the ECHO project? And would it be appropriate for health centers to reach out to local law enforcement for something like that, or even to put together infographics, in your experience?
Yeah, what a great concept. No, I would say no, that they're not, because ECHO, at least this part of the ECHO project has been geared toward healthcare practitioners, but that doesn't mean that there couldn't be a bridge to law enforcement. I know Department of Justice is very interested in bridging that gap. And Elizabeth mentioned our multidisciplinary teams that are available for elder abuse consultation in many states. So when you can have a medical expert and you can have a law enforcement professional in the same room discussing a case of elder abuse, talking about capacity, really good results happen. So I think, Peter, you brought up some interesting concept for us to bring up to DOJ on you know, maybe how we could strengthen some of that communication.
And just to add, Julie, on Peter's question about, you know, letting law enforcement know about what resources are available, if they don't know about EGLE, I mean, definitely, I think it would be appropriate to just let them know that that exists, and that is targeted for law enforcement. Something that was hugely helpful to me that you'll see floating around as you kind of dig in more on elder abuse is that the language that we use in social services and then in healthcare can sometimes not match up with the language that law enforcement uses. And so helping them understand, you know, it's not just like a family dispute where someone took advantage of grandma, but that it's like theft, like putting it in their language can be very helpful.
Yes.
And that's where those tailored infographics are so exciting to think about that. It's such a great point, Elizabeth. Elizabeth, may I ask, there's so many things I want to ask you, but I'm really glad that you talked about self-neglect and how difficult that is to deal with. Can you say a little bit more about that? I mean, for based upon your experience and your broad reach here.
Yeah, so self-neglect is something that you know, Kristin talked about a living document. The body of evidence around self-neglect is constantly evolving. We do know from the National Adult Maltreatment Reporting System that a little bit more than half of the cases that are reported to Adult Protective Services do not involve a perpetrator. So they are some kind of, you know, suspicion of self-neglect. Oftentimes that ties in with behavioral health concerns. What is really important to keep in mind is that Adult Protective Services is always going to balance safety of the individual with their autonomy and self-determination. And sometimes it can be hard to remember that adults have the right to make bad, air quotes, choices. So I think that all of these issues are really thorny. We want to support people, let them know what options are available to help them, but not, you know, be too paternalistic or overreaching in trying to understand why someone is it a choice or is it a, you know, a incapacity or need for assistance. So we have to be very sensitive in trying to tease out those issues.
Thank you all very much. And with that, we have the end this very informative presentation. Two things I ask that everyone on behalf of the National Center for Equitable Care for Elders, please fill out the evaluation. If you have suggestions, as Dr. Reedy mentioned, for additional trainings or webinars, please put them in. And I would encourage all of you to share this recording and these resources with your colleagues who were not able to be here today. This is a very rich body of information here. And I thank our panelists very, very much. Dr. Reedy, you want to say anything?
Just to thank all of our panelists and Dr. Marimaldi for facilitating our session, and for all of our participants. We really appreciate you attending this important session, and certainly we are all freely available. If you have any questions, we can put you in touch with any one of our speakers, and thank you again for taking the time to attend today.
Thanks, everyone. Let's take care of our beloved elders.